This is trauma case analysis regarding an OCI simulation at Duke University on February 2016, presented by jphilip. The case study is a 38-year-old female, Miss Sarah Collins, that was in a head-on collision with another car that intruded into her car. Sarah's co-worker was riding with her and died at the scene of the accident after being thrown through the car. They were both wearing seat belts. It took EMS about 45 minutes to extricate Sarah. She was confused at first. She had bruising to the left flank area, left tib fracture, blunt trauma to the abdomen, and pelvic fractures. She had no apparent head injury. Vital signs were stable when she arrived to the ER, and she was talking. So when you're looking at a trauma patient that rolls in the door, what does the physical assessment look like? Well, there's multiple people, multiple things going on, but the main thing is to follow your ABCs. You want to make sure they have an airway. You want to make sure there's no obstruction. You want to make sure that it's intact. You want to make sure they're breathing. You want to make sure they have good oxygenation, there's good aeration. Circulation is very important. Trauma victims are high risk of bleeding and hemorrhagic shock. So checking the pulses, checking the skin, checking the capillary refill. You need to make sure all of that is working correctly, or if there's bleeding, stop the bleeding, because you're going to be stabilizing these patients at the same time you're doing your assessment. Disability, you want to look at their neuro, see what kind of neurostatus they have. Is it a physical disability or is it a neuro disability? And then E for environment. I know this little picture says examine, but it's really environment or exposure. How long was a patient away from assistance for the injuries? How long did it take the patient to get to the hospital to start getting help on whatever injuries there is? So that can be also a factor, because there is that golden hour on a trauma patient. What kind of injuries should you be concerned with? It would be based off of the mechanism of injury. So with her, you had a high fatality, had a person die. So you know the crash was pretty traumatic. So you would be looking for some pretty horrific injuries in her. So mechanism of injury is pretty much can give you an indicator of what type of trauma you're going to be looking at. And then when you're doing your assessment, this was one thing that I noticed. No one was checking pulses in our simulation. So I thought that's a good one to put in here, that I was the observer. So I think that's important. Sometimes we get so focused on the fractures and the bones that we forget to do the full assessment. So full assessment means turning them, seeing their whole backside, making sure there's nothing there that you're missing, looking for more exposed areas or bones protruding, that kind of thing. Can't say enough about the physical assessment when they first come in from a trauma. That'll be your saving piece if you catch those little things that sometimes end up being big things. Again, the focus is stabilize, 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 and then do your primary assessment. Patient starts declining within that time frame. You go back and do another assessment and figure out what is it that you missed and why has the patient continued to decline. It means we missed something. Hemorrhagic shock is probably one of the biggest things for trauma patients, along with brain injury, and sometimes it doesn't get recognized until it's too late, or that the different stages of shock. You also want to be looking if it was blunt trauma versus penetrating trauma, and it really, blunt trauma is going to be harder to assess. So, because you can't see it, you can use the FAST exam, and if you get a positive, then it helps to speed things up a little bit to know what areas you need to focus on. A CT scan can show certain things that um, an X-ray can't, and for penetrated trauma, FAST exam is not useful. So um, I guess you could use it if you thought you needed to, but and then exploratory surgery is done sometimes when they can't figure out the mechanism of injury. Um, they'll go in and just try to see if they can find out what's wrong with it. So in our case scenario, the patient was getting worse, and we had to decide on what was wrong and deciding if it was the mental status was declining and respiratory was declining. Was it related to a brain injury, or was it related to hemorrhagic shock? Well, I think the recognition of, yeah, she's bleeding was there, but I don't think the urgency of where she was bleeding was recognized. So, how can we tell the difference between a neuroshock and a hemorrhagic shock, and how that will affect how you proceed with management? And neurogenic shocks, a lot of times the patient's still going to be warm, have warm extremities, and putting out good urine output. Whereas hemorrhagic shock is just that they lose fluid, so they're cold, they're actioned, their pulses are minimized. It's very profound when they've lost a lot of blood. But this is when you stabilize a patient, that use the FAST exam, and then make sure you order the appropriate x-rays, because you have your key areas, and then it's basically your spine, your C-spine, your pelvis area, and your brain area. So make sure you get those done after or while stabilizing the patient. I put this in there because it would seem like both groups had missed this, and I would have missed it had I been in the room. I did not know about the sheet protection for trying to tampen on a pelvic bleed. So I think it's important to be exposed to this, and there's the information if you want to look at it. And I just used Up to Date and found it, and I think it's important to understand what you need to do to stabilize the patient on top of what is wrong with the patient. And finally, we talk about trauma and all of the fast pace of trying to get a patient stable. But a lot of times there's family members in the background watching every move that we do, and they have questions, or they don't know what's going on, and they're just hanging out because they want to know. So it's important. With this gentleman, he was talking with his wife when the car accident happened, so he might have some type of blaming going on to himself, and he needs to be reassured about that. And also, we need to provide social and counseling for families with traumatic injuries, and have a discussion with them about how they're going to um, be around or supportive, or what their work looks like, to see where we might can help. In his case, it would be important to let him see his wife, give him the specific details of what injuries she has, and make sure that at the beginning the patient and the husband are able to communicate to each other, and then update them many times and keep them in the loop. I think that's very important with trauma patients. So let's recap. We needed to understand the extent of mechanism of injury. Um, in this case, it was a motor vehicle accident where the car intruded to her, causing a fatal injury. So understanding that can guide you with your assessment and finding out where things are not so good. We talked about the difference of blunt and penetrating trauma, where blunt trauma is going to be harder to find, and then we talked about the trauma-related shock, where you've lost 30% of your blood, and you have basically class 3 hemorrhagic shock, and you haven't had any recovery from that. It's not a good mortality at all. So it's important to know what the shock levels are, and understand which way you're headed when it comes to the types of trauma shock. And then trauma in families in general is PTSD with family members and with them trying to take care of their loved one. It's important to have that social connection, social support, and I think that's about it. And if anybody has any questions, or I hope you enjoyed this, and I learned a lot from this case study, and I think I'll be prepared a little bit more when I